So today I'm here with Angie. We're going to talk about how to evaluate somebody who comes in with a rotator cuff-like presentation. The first question that we want to answer is this arising from the cervical spine or is it a true rotator cuff problem? So a couple of things we can do is number one, range of motion. When that patient says my shoulder's killing me, but this is my range of motion, it's probably not their shoulder. Another thing that makes us suspicious of a potential cervical complaint is if that patient has a shoulder abduction sign, where they like to stand with their arm up above their head. So they sleep at night with their arm resting up on their head. They walk around like this anytime that it's painful. They're trying to take tension off of these cervical nerve roots, which is what's producing that pain in the arm. And the last clinical test that I love for this is the arm squeeze test, squeezing that patient's arm. If they have a rotator cuff problem, very little trouble with that. But if there's an irritated nerve root in the spine that's causing that, that test is going to be positive, fairly sensitive and specific for that rotator cuff issue. Now, once we've said yes, it's probably the rotator cuff, what are we going to do to determine is it full thickness, partial thickness, or a rupture? First of all, the rupture, if the tendon's completely gone, the patient's range of motion is going to look something like this. But the other test that we can do is the drop arm sign. Now we take their arm up and I'm going to hold and support their arm, and a patient with an intact rotator cuff should be able to lower their arm okay. Somebody with a tendon that is torn, as soon as I let this go, they're going to let that arm drop. Now it may be actually a little less painful if the tendon's ruptured because nothing's being pulled on. But when they have pain when they let that down, but they're able to control it, that gives us a good indication that there's probably a tear. In fact, the Journal of Shoulder and Elbow Surgery just last month told us that's one of the tests that's most sensitive for a rotator cuff tear. The other test that we put into our exam is Neer's test. So we take that patient's arm forward and take that up into abduction. And I'm stabilizing the scapula in this instance and taking the arm through that impingement zone. And if there's pain in that case, there certainly could be a rotator cuff tear. The combination of Neer's and the drop arm test are the most sensitive tests, are the best combination of tests to detect a rotator cuff tear. The other test that's particularly specific is the PAT test, and sometimes we call this the hornblower sign, where that patient takes their arm up to 90-90 and I'm going to resist external rotation. That test is 99% specific for a rotator cuff tear. The other test that's helpful to rule out a tear is the empty can or the Job test. So the way that this works is the patient takes their arm up as though they're dumping out a can, and I'm going to apply a little resistance downward. When that test is negative, it's 81% sensitive that there's probably not a rotator cuff tear. Two other tests that are really helpful that have come out in the last couple of years is number one, the external rotation lag sign. So in this test, as the name implies, we're going to take this patient's arm into a little abduction and external rotation. I'm going to take her arm back, and then a patient with a good rotator cuff that's not torn should be able to hold that. Somebody who is not intact rotator cuff with a full thickness tear, now when I let that go, it's going to hurt, and they're going to retreat and say, that's uncomfortable. Perfect. The other test that we can use for this is the dime test. So the dime test stresses the supraspinatus tendons in two different planes. First, we're going to have that patient take their arm straight up against just the resistance of gravity, and then I'm going to push back down. So now they're going to have an eccentric contraction at about a 5-second count as I take it down. We're going to test that in two planes, both laterally and then in the scapular plane, where she brings it up again on her own power and now resists me over 5 seconds, taking it back down. The dime test is quite sensitive for detecting a full thickness tear, much like the external rotation lag sign. So now we say a patient has a tear, what we want to identify was this preceded by some sort of impingement? Was that supraspinatus tendon getting pinched underneath this acromion? And in 95% of cases, that answer is yes. 5% can be traumatic, but Charles Neer told us that the vast majority are happening because of impingement. So our three tests for impingement, one of them we've already done, that's Neer's test, taking her arm straight forward. She says, ouch, you're pinching my supraspinatus tendon underneath the acromion. The next test is Hawkins-Kennedy test, bringing her arm in front of her body as though a hawk is going to land on it. And now when the hawk lands on that arm, there's going to be some pain with that. And finally, a painful arc. So when we ask her to bring her arm upward, all the way up, there's usually going to be pain between about 60 and 120 degrees. So when ouch, it hurts in there, and now she gets above that and the pain goes away, it tells us that there's probably something happening in that zone of impingement. So Neer's, Hawkins-Kennedy, and a painful arc, pretty good measure that yes, there's some sort of impingement. Now, Dr. Charles Neer also told us that those patients with impingement always have scapular dyskinesis. So really the foundation of our shoulder exam is, did this start in the shoulder blade in the first place? That when my arm comes up, For every 2 degrees that my glenohumeral joint moves, my scapula needs to rock 1 degree. And if that rhythm is out, there's going to be a problem. So we're going to take a look at the scapula. First thing that we're going to look for is there any winging? We could put the patient in an all-fours position, rock them back and forth, and say, now is there any winging of that scapula? Can we get our fingers underneath that scapula? But most importantly, does the scapula move in the right rhythm? So as Angie brings her arm up here, I'm monitoring and saying, what's happening to the scapula? Keep going. Does it move 1 degree for every 2 degrees of glenohumeral movement? And if we see that there's an abnormal rhythm, a potential problem, especially if there's a lag or some winging. So when we see a dysfunction of the scapula, what we're going to do is artificially stabilize or mobilize the scapula and see, does that improve it? Because that'll direct us toward our treatment. So if we suspect that there's a mobility issue, I'm going to help it move. This time when she takes her arm up, I'm going to rock along with that, taking her shoulder blade along with her glenohumeral joint. And if that relieves the pain, that tells us she needs a more mobile scapula, so we need to give her some scapular mobility exercises. The other possibility is that it's a stability problem. So in this case, there's going to be winging of the scapula, and what I'm going to do when she takes her arm up is to hold that angle of the scapula against her thorax, making sure that I'm not pinching down on her shoulder to pinch the rotator cuff tendon. And if I hold that scapula in, doing what the serratus anterior should be doing naturally, and it helps, it tells us she needs stability, especially of that serratus anterior. So I hope that this has provided some good information. If you'd like to review any of these tests, you can visit the website to do that. More importantly, if you'd like to see the protocol for what to do once you find a positive test, we have that, and most importantly, we have the ability for you to deliver that information to patients in a couple of clicks. If you've not already checked it out, visit chiroup.com. Thanks for watching.